see gunshot wounds, that would be considered a penetrating traumatic brain injury. You will see levels of consciousness. Good afternoon, everybody. For those of you who don't know me, I think most of you do, my name is Danielle. I'm one of the rehab nurses down on the brain injury unit, and today I'm honored to present a brain injury presentation about traumatic brain injuries and the Rancho scale. In each level, how we're going to interdisciplinary work together to help them achieve their goals and be safe in their own environment here as well as on the outside. And thank you to everyone for giving me this opportunity. We're going to go over some basic information and then delve into the Rancho scale. So for a basic information of the brain injury, basically it's a blow or a jolt to the head, or it can be a penetrating injury. Unfortunately, with violence these days, we do see gunshot wounds. That would be considered a penetrating traumatic brain injury. You will see levels of consciousness that change at times, behavior and cognition, as well as physical limitations. All the reasons why they're here with us so that we can get them better and get them home. There are ranges from mild to severe, and they result in problems with independent function, and that's everyone works together to help that. Right now, the statistics are about 1.4 million people annually result in a traumatic brain injury and over 50,000 deaths per year. Hospitalizations are 235,000. And the adults over 75 are their greatest risk for hospitalization, which tends to be most of our population here, as you guys know, working with the brain injuries. Our most common causes are motor vehicle accidents, accidental falls, especially in the elderly population whose balance is already decreased. And then we have gunshot wounds, as we talked about, and sports injuries. When I did this presentation for the doctors, I pointed out football and the CTE that's coming along with the research about traumatic concussion, constant hits to the head, and how it's altering these people's mental states and causing some serious problems. Dr. Berlin pointed out that it actually started with boxing, was when they first realized how important or how dangerous certain sports can be towards brain injuries. So this has been ongoing since the 80s. 75% of the cases that they see in the ER are mild brain injuries, like our concussions. We'll get into that in a moment. 80 to 90,000 people in the United States actually experience long-term disability. This is why it makes our job so important, because after rehab, they may need to go somewhere else. We have neurorestorative, which is around the corner. We have other outpatient centers here that help them. And the progress for brain injuries is really slow sometimes. I hear doctors start telling our patients' families all the time, it could be a matter of a couple of years before you really start to know exactly where your loved one's going to be, and you have to be patient, and you have to be accepting of the situation, and every step is a big step. There are two types of brain injuries, open and closed head injuries. Falls for closed head injuries, motor vehicle accidents. And then we get into the focal injury, which is just one part of the brain that's injured. And then we have the diffuse axonal injury. This injury is a little bit more difficult to treat because there are multiple areas of the brain that are involved, and the neurons shear and pull apart, and the neurons have a lot of trouble reconnecting. And so patients are going to have difficulties in more than just one area. You may not actually see this on a CAT scan, so it's because of the work that you guys do here that we can really see the effects of these types of injuries. Your categories of brain injury are broken down into mild, moderate, and severe brain injuries. On a mild brain injury, you're going to see a normal brain scan. We talk about concussions are the most common thought of a mild brain injury. You may not lose consciousness at all, but if you do, it's not going to be for very long. You may have temporary effects, but like I talked about with the CTE that they're doing research, the more cumulative effects, the more dangerous it can be on your long-term recovery. For a moderate brain injury, you can have loss of consciousness for up to 24 hours. You may have a good recovery, but you're going to probably have to learn some compensation techniques, and that's what we teach them here. And then our severe brain injuries. This is why we're here to learn about how to focus on these brain injuries. These are going to be the ones that are going to be here the longest, and these are going to be the ones that we're going to be working with the families closely to make sure that everyone's aware of the best strategies to use in order to help them. These ones, you'll lose consciousness for more than 24 hours, but you're most likely going to have permanent brain damage. If you look on this slide, it talks about severe brain injuries can also be broken down into 4 categories. When I first did my research, I didn't understand why a persistent vegetative state was actually a little bit better than a vegetative state. But after understanding it, you didn't slip back into a coma, which is a good thing. So we're getting somewhere. And then a minimally responsive state is where we're going to see our first couple levels of the Rancho scale. Most likely we're not going to see them here yet, although we have seen a Rancho 3 here before. And we'll get into that in a few moments. Symptoms of a mild brain injury: you can get blurred vision, confusion. Some people report being tired all of a sudden after receiving concussion, like a mild brain injury. Some memory impairments, headaches. Again, some things can be led to other disease processes. So that's why it's really important to do your research into the situation, figure out exactly what happened. Sorry. Severe brain injuries, you can see seizures, you can see comatose states, agitation, poor coordination, slurred speech. These are the ones that the families are probably going to be able to pick up more on. However, again, some of these things can relate to if they're under the influence of something. So again, it's very important that we all work together to make sure that we figure out what's going on. The Glasgow Coma Scale, for anyone who's not aware of what it is a measure of your function when you get within 24 hours after you get your brain injury. They normally do this on admission into the emergency room. Now, 11 to 15 means you're able to communicate with them. You could be perfect. A 15 is a perfect score, like those of us sitting here today. 91% chance of a good recovery. Now you look down at 3 to 4, they're basically in a coma when they get there. Very decreased risk of a good recovery, decreased chances of a good recovery. We've talked about concussions. You have contusions on the brain, like a bruise, and these can be moderate or severe. And the outcomes are going to depend on where it is and also how severe it is. This is an interesting fact that I've discussed with Dr. Stern on multiple occasions, this coup contre coup. Basically, it's a bruise on the front of your brain and the back of your brain. These can actually happen from car accidents, like a whiplash, or even a roller coaster. So who would have thought that going to Disney World or Six Flags could actually cause you a possible brain injury? But it can. That's why they tell you to hold your head back and not move. It hits the front of your skull and then it hits the back of your skull. A lot of people think originally, and this was my thought process when I first entered nursing school, I thought my brain was stuck in the same place. I didn't realize it could move all around. And this has taught me that it can, and these are the kinds of things that happen. This is why also they talk about children and making sure they're secured enough in a car seat. You have different kinds of injuries. These are hemorrhagic injuries. There's a couple that I'm just going to briefly go over. You have your subdural hematomas. They may be acute, subacute, or chronic. So we have patients that have had subdural hematomas forever. And we may see a change in their behavior, and we send them for a CAT scan, and it shows, oh, well, you have a chronic subdural hematoma. So what do we do with that? We treat it like it's been being treated. Now, if it's acute, that's a different story. We probably end up sending them over to the hospital for evaluation. The biggest thing here is you may need to get it surgically removed, but it only depends on the size. If it's more than a centimeter in an adult, most likely they're going to remove it. Smaller sizes, we may just do medication. Your epidural hematomas, to be honest, I haven't seen too many patients with these epidural hematomas here at BACRAC. It develops because of a venous bleed or an arterial bleed that's associated with a skull fracture. This only accounts for 2% of these kind of bleeds, of any kind of bleed. So again, it's not very common, but it's still important to know about. These, most of the time, you need to get surgery. And the biggest thing is changing levels of consciousness and also an elevated intracranial pressure. Some children, when they're diagnosed with problems in their brain, they notice that they start vomiting. That's because of an increased intracranial pressure. So you may see that with an adult as well. The important thing is to make sure that you rule out any other problems before just jumping to something less traumatic, instead of making sure maybe there is a brain injury going on. Your intracerebral hemorrhages, again, you're going to see headaches, possibly even a coma, and signs of herniation. This is very dangerous because these patients struggle to come out of the hospital if they're having herniation, especially if it's back in the brainstem. We'll hit that in a second. Your subarachnoid hemorrhages, this is another type of head injury that we see very commonly amongst our brain injury population. It can be because of a severe brain injury or an aneurysm rupture. Each of these slides, as you can see, have little pictures that I've associated with areas of the brain. We talked about the brainstem very briefly, but just to let everyone know, this is a very important area of the brain that actually helps with your pulse, helps with your respirations. If this area is damaged, these patients are going to have a lot of difficulty with their normal functions to be able to live. Also, you'll see sometimes, for instance, there's a pons in that section of the brainstem. And these patients, often you will see if there's an area that's damaged, you could see trouble with walking or something like that, balance, because it's so deep into that area where your balance and coordination center is. So for us, we're looking at safety, making sure they have alarms on. I know those alarms go off all the time in here, but it's because we don't want them to fall. Your cerebellar injuries, everyone thinks of coordination and movement. Some reflex motor acts, things that you would do all the time, are led back here. So ataxia, tremors, inability to make rapid movements. Again, the concern for any of these things is that the patient gets diagnosed correctly, because other things can cause tremors and vertigo and dizziness. Vertigo could be the actual diagnosis, not a brain injury. So it's important to work together with your healthcare professionals. Your temporal lobe injuries have to, on the sides of your brain, as you see in the picture, have to do with your memory and your language skills, your ability to hear, because it's right by those ears. Short-term memory loss and unable to understand spoken words, or Wernicke's aphasia. This is our receptive aphasia patients, that it's very difficult, because I've actually had a patient who, she would say hello and ask a question, and she didn't understand that we were responding to her, and she got very upset because she just kept asking the same question over and over again, because she really had no idea that we were actually responding. It was a very difficult situation to handle. Your parietal lobe has to deal with your perceptual issues. So this, you'll see different problems with hand-eye coordination, reading, finding words, or writing. Just one quick example, I had a patient, he was a stroke, but he had it on the parietal side. He went to go pick up his phone because the phone was ringing in his room, and he picked up the fork, and then he picked up the spoon, and then he picked up the remote, and then finally we figured out that it was the phone that was ringing. He couldn't figure out different objects. And then your occipital lobe, which a lot of people think about as vision, is primarily, that's the biggest thing, it's vision. Visual perception and reading. Your word blindness, which speech I'm sure sees a lot, is the inability to actually recognize the words. So they're going to have trouble with reading and writing. And then your frontal lobes, your expressive language, your ability to tell us what you want. They get very frustrated very quickly, as any of us probably would if we couldn't express ourselves. They can't focus on more than one task, and they have difficulty with problem solving. There's an area in the brain in the front that's the prefrontal cortex. This has to do with personality and behaviors. A lot of times the family members will come up to us and say, I don't understand why my family member is acting so different now. Now, I've had one situation where they said they were acting nicer than they were before the injury. He actually said, I love you and happy Valentine's Day and all that, but most of the time we see the opposite. So it's really important to make sure that these families understand really what's going on in their brains. And we have many resources on the unit. There's some books out there that I know Dr. Stir likes to talk about sometimes and gives the patient's families these books to learn more information. Now into the part where we need to work together as a team at Backrack, like we already do, to really help these patients succeed. The Rancho Los Amigos scale was developed so that everyone could speak on the same lines about how these patients are doing in their recovery, in their everyday life. Now, it used to be 8 phases. Now there's 10. When you look in them, 8 through 10 are pretty similar. So there's not too many changes, but everyone has to change something at some point. So there's actually a Rancho Los Amigos hospital out in California. I was hoping to go out there last year and visit during an ARN conference. I couldn't get there, but it would be an amazing experience for anyone that's interested in brain injury to actually go out to California to this hospital. This is where it all started. So my goal of this presentation in understanding Rancho is really to make sure that we all talk on the same lines. We're going to integrate this into the PECs. We're going to integrate this into our everyday language so that everyone knows where these patients are at, how to help them, how to help us, and how to help their families. After this presentation, it's also going to be hopefully rolled out to the nurses as well, so we'll all be able to work together in a continuous environment. So your level 1 Ranchos, these patients are not responsive. They're in a coma. We're not going to see them here, but they need total care. Even if you're working with these patients, you go see them in the hospital for an evaluation or something like that, you still need to talk to them. We don't know what they can and can't understand. So it's really important that you treat them as any other human being should be treated, with respect. Your level 2s, they're inconsistent with their response to pain. So sometimes they may jolt, sometimes they may not. It really depends. Their responses are going to be significantly delayed. I know a lot of people are kind of iffy, me too, about silence and just complete nothing happening, but give these people time, you may see a response. Don't feel awkward about silence or anything like that, because we grew up in a society that taught us, oh, awkward silence, that's not good. But for these patients, this is the start of them healing. You're going to see each section has interdisciplinary management. That's all of us together. We're talking to these patients at a Rancho 2 in a normal tone, using simple phrases, and telling them who you are before you talk to them, do anything with them. Your level 3 Rancho scales are the ones that you may start seeing here at BACRAC. You may have had a few patients of your own that remind you of this topic and category. They're starting to track, follow your movements with your finger. They're responding to pain more appropriately, and they can start to follow simple commands, but it's not always consistent. They do turn to sound. Currently, actually, we've had a few recently, a brain injury that really just came out of a 3 and is kind of out of 4 or 5 now, which we'll see in a second. But went from kind of turning to you when you said the person's name to now completely out of that range and progressing. But it's important to know that they don't progress on a normal scale of 1 through 10. They can go back and forth between a day, between a shift, between the hour of your therapy session. That's why I want everyone to understand this, so that when we're explaining to the doctors and the staff, hey, this is how they're acting, we can kind of graph and see what's going on. It's a more visual aid for the families as well, because the families are really important in this. For your level 3s, the sleep-wake cycle is really important. We have something on the unit where we have a schedule, basically, and it tells them, okay, you have therapy at this time, you're going to sleep at this time, and no TV here. And it's really important because it gives them that structure. It also gives the staff the structure to make sure that we're keeping to that idea. Now, your level 4 Rancho levels, they're confused and agitated. This is the biggest thing to know about this patient. They're agitated. We've all had our agitated patients here before, and we've all run into situations where maybe it got a little bit escalated. The goal by learning about this is to de-escalate those situations before it gets there. I'm lucky enough to be part of the brain injury team here at BACRAC, and we've discussed having possibly a team that responds to situations with an agitated patient for people that are really trained on how to de-escalate. Unfortunately, we had a patient here who had a code gray called on them on Renaissance. Some of you may have been here when that happened. The reason it happened was because that person was on a 1-to-1, because they were impulsive and they were agitated. And the person says, oh, what color is the sky? And they said, orange. And the person goes, no, it's blue. They said, no, it's orange. No, it's blue. They argued back and forth. As soon as I heard that, I realized what went wrong. You can't argue with a brain injury because they don't understand any of the consequences that happen. And who cares if the sky they think is orange? Let them be happy for a little while. Go with it. These people have very short attention spans and mood swings. We have to be very consistent and limit it to 2 visitors at a time. Now, we have a 2-visitor policy on brain injury already. But when you're in the gym, sometimes there's too much stimulus. Brett takes his patients sometimes into this the room where the eye doctor comes to give them less stimulation, but still have them out of their room, because that's really important as well, to start to try to rehab them outside of the room environment. For nursing, we have to do it in short blocks. We can't go in there and try to think that we're going to spend an hour with these patients. It's not a good idea. And because they don't have short-term memory, consequences don't work. Your level 5s are confused, but they're not agitated anymore. So they're a little bit easier to get some information through to them. They're still not aware of their safety though. Because of not being aware of their safety, they still may be on 1-to-1, or they may have a wander guard, which you'll hear the bells going off. Or they may just be line of sight in front of the nurse's station. From a therapy perspective, making sure that these patients stay safe is going to be one of the biggest things. They still have severely impaired memory, but they can respond to commands now. Again, we're limiting visitors. Speech therapy is going to start introducing the memory aids, the memory books. Positive feedback, repetition, and using short, simple questions. Your level 6s, they're confused, but they're appropriate. They're following commands consistently. The biggest thing, again, is safety, positive feedback, and structure. Structure is really important, and on the weekends, structure is difficult because you guys don't have therapy as much on the weekends. So it's really working together to make sure that they have a really good plan in place. And this is important when they get home too. Your level 7s we call kind of robotic. They don't need as much motivation to do things, but they can't necessarily recognize inappropriate social behaviors. We've had people that are sexually inappropriate at this level, where they're grabbing people in the gym or something like that, and need to work together to make sure that we keep ourselves safe as well as the patients. Your main goal starting at level 7 is getting them back into society. Do problem-solving tasks with them. Occupational therapy, I know you guys do it, we all do it, but we all need to continue to do it and all be on the same page. And we need to treat these people as adults with respect and dignity. Your level 8s, 9s, and 10s, as you'll see in a second, are very similar. They can get easily angered, they can be argumentative, they may need some supervision, but they are oriented and their memory's intact. These people you'll see out in the community, these 8s, 9s, and 10s. You may notice them to be a little off because you understand a brain injury, but really they can focus in society, and that's a good thing. You're going to need support on the outside, outpatient support. Encourage independent functioning, and encourage the patient to use their own problem solving and judgment. Again, these guys are going to come back for rehab, they may go to neurorestorative, they may just go home and get inpatient therapy at home, or home therapy. But overall, we're all still going to be working together to make sure these people stay safe and get the best quality of life that they can. Your level 9s and 10s can still be irritable. They get low frustration tolerance when they're sick, fatigued, they're under a lot of stress. And when I presented this to the doctors, they all started laughing and saying, I think we could all consider ourselves a level 9 or 10 at some point. Because we all get stressed out, and we all get frustrated a little bit or sometimes. But you know what? This just proves that these people, these brain injuries, are able to interact appropriately in society again. We're going to continue to see them in our society, and we just need to make sure that we continue to treat them properly and work with their needs. If they have something that they need from us and they're struggling to tell us, give them a second, give it quiet, and try it again. These guys can play games, but again, it says prepare for discharge. Dr. Amos said to me, I don't think we'll see these patients here because they're probably home at this point. Insurance probably wouldn't let them stay any longer. And although we talked about the Rancho and traumatic brain injury, I did want to throw in this last slide about non-traumatic brain injuries. These brain injuries occur without damage to the skull, primarily strokes, aneurysms, brain tumors, unfortunately we see that. And the biggest thing here, there's this anoxia one. We had a patient once, 15 minutes he was down, he suffered a heart attack. He became extremely inappropriate, and we could use the Rancho scale on him from a ability to talk amongst each other, but Rancho's for traumatics. But this gentleman did follow the scale of the Rancho. He was very impaired, very sexually inappropriate, and actually by the end was doing much better. And that's a testament to everyone here to see these patients go from not being able to function to being able to go home. And everyone should be extremely proud of themselves for what they do here and work together. And that's my bibliography. I have one thing that I was really excited to show you guys, but I just wanted to see if anyone had any quick questions or anything like that before I show you this real fast. Okay, hang on. I worked really hard on this one, and guys, some of you may have heard it when we were loading this up.